Okay. Patricia, are you going to say a few words or should I proceed?
You can go ahead, Dr.
Okay, thank you. I
Hadjipatis.
guess we're not doing CV. Good,
Nope.
good morning, good afternoon, good evening. I'm really excited about introducing this webinar in our series of global neurosurgery and a tumor board. This is a great event that brings together continents from all over the world by experts who can really provide their thoughts on cases. I hope you can join us, and these are all recorded for future viewing on the Tumor Section website. I'd like to thank Dr. Kate Drummond and Walter Stumer for organizing this as the co-chairs of our Global Neurosurgery Subcommittee of the section on tumors. I'm going to hand it off to Dr. Drummond and Dr. Stumer to kick this off, but once again, I want to thank the AANS, Patricia Kaminsky, for helping us organize these webinars, and real excited to be part of this. Thank you very much.
Thanks, Costas. Kate Drummond from Melbourne, Australia here, and Walter Stummer just joined from Münster in Germany. We've got two case presentations tonight from young neurosurgeons, one from Dorothy Spiller from Germany and Sarah Kane from Australia. And we've got a fantastic panel here, including, and when each panel speaks, I'll ask them to introduce themselves rather than going around, but including neurosurgical and neuro-oncology and neuropathology expertise. Walter, we decided that Dorothy would present the first case. So, do you want to moderate the German half of the International Tumor Board?
For sure. We'll switch to German to do that. No, we won't. We'll do it in English.
No, don't
No,
switch
thank
to
you.
German.
You've said it all. And also thank you to Costas and Patricia, as always, and to Maria, who have been instrumental in organizing this. So I'd like to introduce for this first speaker is Dorothea Spiller, who's a young neurosurgeon here in the faculty, specializes in neuro-oncology and also in pediatric neuro-oncology. So she's prepared a very interesting case, I think, with a lot of surgical and other aspects. So Do, where are you? She here?
Yep, she's here.
Oh,
You want to
okay.
share your screen?
Yes, I'm here. I share my screen. Wait a
There it
minute.
is. Okay.
I'm sorry. Okay, perfect. Can you see the presentation?
Yes.
Yes.
Yes, okay, perfect. Thank you for the kind introduction and for the opportunity to present a case from our neurosurgical department. So, as Professor Stummer said, we're talking about a case concerning management of multifocal progression in molecular glioblastoma. So first of all, let's talk about the clinical course, and then about surgical strategies, about the molecular findings, and therapeutic options. I brought a case of a 40-year-old right-handed male patient. He presented to our outpatient clinic with focal motor seizures of the left arm. The neuro exam was unremarkable, and at a smaller hospital nearby, levetiracetam and dexamethasone had already been prescribed. First of all, they took a CT scan, which reveals this diffuse hypodense lesion in the right insular region with mild local mass effect and displacement of cortical structures. There's no intralesional hemorrhage, no calcification, no vasogenic edema, no midline shift, hydrocephalus, or acute ischemia. And then for further characterization, they performed an MRI scan where you can see this diffuse right insular tumor and the lesion in the right frontal lobe, which suggests that there's a multifocal pattern. So the question is, what are the differential diagnoses? Does anyone want to say something, or shall I go on?
Walter, you can call people out if you like.
Oh, okay. I have that power. Okay. Well,
You have all power.
I'll just talk to the panelists so they might briefly introduce themselves, Aristoteles, and maybe say a couple of words what he thinks, and then maybe ourselves and some of the others later.
Yes,
Great.
I think as we don't have like any contrast enhancing lesion, also like maybe an infectious lesion or like a focal infection lesion or lesions like there are also multiple sclerosis lesions that can look like maybe malignant lesions. This could also be a differential diagnosis, I think, in this case.
Okay. Anybody else? No.
This does look classic for an insert glioma in this context, and I would love to see a coronal view for the anteriorly originated insert gliomas from the short gyri of the insula. Their classic spread to the posterior orbital frontal lobe, as well as the medial anterior temporal lobe, as seen on that first axial scan, seems consistent with the Marcel mesothelin compartment concept of the paralimbic region. What's a little unclear to me in the second image and the fourth image is whether this extends into the suboperculum or how much in the pathway of extending to that subcortical frontal lobe, which sometimes the extension of the suboperculum is more likely in the two gyri that's around the central sulcus of the insula, but maybe a little bit easier to tell on a coronal view.
So I think that seeing that area is a good catch because that's exactly the point. And I'm not sure if we have a coronal view, but I can tell you it's not directly attached. So there's at least two foci. That's one important point. And I think the other point that we want to make, Dora, was about predicting whether it was an IDH mutated tumor. Is that correct? Or
Yes. So we suspected that it's a low-grade glioma. And then when you have a look at the T2 sequences, you see that there is a mismatch. There's no mismatch sign. So this is indicative of an IDH mutant astrocytoma, as you said. Yes.
Okay. So would anybody suggest any? So you said, of course, obviously we have the coronal sections, but we don't have them. I don't think we have them prepared here, but that's a very valid point for planning the resection. No, the other point I want to make, anybody would require any other imaging here? And then sort of a
Walter, in Europe, you have FET PET. Is that something you would have
exactly
gotten here?
exactly. So there's two reasons for that, if I may, or for doing the FET PET first, if there's a hotspot, right? And then to see if that hotspot, the dynamics of the hotspot, to see if we can't make a prediction about the dignity of this tumor. Is that correct, Doro? I think
Yes.
that's what we did.
So I can show
Okay.
the FET PET. We have it here.
Right.
So you see that there's a moderately intense patchy FET uptake of the right insular lesion, and that SUV, TBR, and kinetic profile are consistent with the low-grade glioma. So we see that there is a slow increase with reaching a plateau, and that in contrast to high-grade gliomas, there is not an early peak and not a really decline as you see it with the high-grade gliomas.
Right. I think one aspect, if you're not so accustomed with these FET PETs, is that there is a lot of diffuse uptake there in the right hemisphere, right? So this is about this issue about this being a multifocal tumor. This is supported by the FET PET, right? So it's more than just the insular lesion. Okay. Any questions regarding the FET PET? Okay. No.
Okay, then perhaps I go on with our surgical strategy.
Yep.
Of course, we did preoperative counseling, and then the patient was scheduled for a microsurgical tumor resection. So we reached it via a pterygium craniotomy and then used the microscope, the neuronavigation, including fiber tracking, then fluorescence, FALA, and first of all, we did a Sylvan Fisher split, sent the tumor extender to Sylvan Fisher, and then using subpilot technique, we resected the tumor and continuous monitoring and mapping to stimulate CST. And of course, we also had to look at the vascular anatomy so that we save the M1 perforators. And of course, we did subcardiac mapping. In the end, we saw that in the middle of the operation, we saw that there was absence of FALR. So this suggests that it's a lower grade histology. And this is also a very important point that we took specimen from the area of maximal amino acid uptake. Now the frozen section allows us said that it was a diffuse astrocytoma, and then in the end we did risk-benefit consideration, which means that we tried to resect as much as possible by avoiding resection into basal ganglia and deep frontal white matter. Then I want to present to you the postoperative MRI. So you see that, as expected, the majority of the tumor is resected, and there are only residual tumor involving the lentiform nucleus. A couple of days later, we got histopathology and molecular analysis. Perhaps Lionel, as an expert in the field of neuropathology, would you mind to comment on the histopathological and molecular findings?
Yeah, so it looks that it is compatible with a molecular glioblastoma. So the match is not perfectly above the threshold that we usually would apply, which would be compatible with the infiltration zone of a diffuse glioma. But I think the chromosomal alterations with +7, -10, and also the homozygous deletion of CDKN2AB, that perfectly fits to the diagnosis of a glioblastoma in this case.
Yes, thank you very much. So I brought a question. What are now our treatment options? What would you recommend?
Before we move on to that, can I ask you about your surgical strategy? Do you always split the fissure, or I mean, I would go transcortical. Interested in what the rest of the panel says.
Okay.
Aristoteles.
Right.
Yeah. So thanks. First of all, thanks for the invitation. It's a great honor and a great panel to discuss with. I think with regards to surgical strategy, from my perspective, and most of the times also for educational purposes, I also acquire a pre-op CTA just to see this nice lenticular striates. I incorporate it in the neuronavigation most of the time to have it as an adjunct. I usually split the sylvian fissure, whether it's a right or left insular tumor. And if it's an awake setting, I usually split the fissure before waking up the patient, so I can maximize my corridor. And then if it's, for an awake, I try to do my windowing with the patient awake. If it's a right lesion, I usually confirm laterality and plasticity with an fMRI as well, and I also try to acquire cortical. So I do a combined approach to maximize the corridor. But of course, the resection here was excellent. So not every surgeon needs a transcortical window. I usually do it to maximize the exposure.
Okay, well, in all fairness, I did do a window, so because usually you don't have that kind of exposure that you require through the sylvian split, and sometimes you have the vessel problems, and the vein problems. So in all fairness, that's what I did here. I just didn't tell Doe, who wasn't with me in the surgery. Okay, but any other ideas about who would do it differently here? I mean, we don't do we get the fMRI, not the fMRI, but we get the MRI with the TUF and also with the T2. I did detailed T2, then you can also see the perforators. So I mean, that's a valid aspect. You always have to look where the perforators are going. And during surgery, I do tend to split the proximal fissure to see where the M1 perforators are coming up, because that would be, the IFOF and the deepest extent of resection for those.
Yeah. And just a comment on the laterality. If it's on the left and you have the patient awake, there are this I would say these two traditional schools. One would suggest that you go and find the functional boundaries, right? You search for the IFOF. The patient has semantic paraphasias, and this is usually before you even see the lenticular striates. And of course, the other option is you just anatomically see the lenticular striates and you stop there. Just a question, Dr. Stummer, how did you address that kind of the second foci, which was anteriorly? Did you have any specific strategy for that? The foci that was anterior to the head of the caudate nucleus?
Well, no, I considered it critical because it's right in the deep matter tract. So I didn't, and it was so diffuse, I didn't aim for that. And I said, well, if it's a low-grade glioma, this is the discussion, obviously, that we want. We will get into exactly that discussion as we move along. But that was my idea. But we can always, so I left that alone, right? I took away the mass lesion that was obviously causing the problems, but maybe, Kate, do you want to say about your surgical strategy? Would you do this any differently?
No. I note online we've got a suggestion of a keyhole craniotomy. I certainly that this is not a keyhole case to me. I think this is something with a fairly wide exposure for mapping and access. But yeah, I would do the same triple motor mapping, more a transcortical approach. I don't routinely split the fissure and a sleep. And I wouldn't be aiming really to go too hard in those deep regions.
Exactly. Okay, so the ALA, we know from the ALA that, it's sometimes very helpful, but we only see in this kind of circumstance, fluorescence that will in any way help us, find a hotspot or something in 10 to 20%, so you might as well not use it. If there's no FET signal, that's just a comment on the side because we're always doing that, but that's a privilege that we sort of have. Okay, so next step, I think if we've now discussed the surgical aspects. Is adjuvant treatment. So we've seen the molecular pathology. It's a molecular glioblastoma. So I don't know, maybe we have here our neuro-oncologist.
Yes, maybe it's a young patient, 40 years. The MGMT promoter is unmethylated. We know that maybe temozolomide or medical treatment might not be as efficacious as we would wish it to be, but still the standard treatment protocol would be like combined radiochemotherapy according to the Stroop protocol from 2005 with temozolomide.
Okay. Is there anybody in these cases of molecular glioblastoma that would not move forward with radiochemotherapy in a young person? Is there anybody here, or is that automatic? It's I think something we always discuss.
What would be your alternative?
Well, we do have some data. This is interesting. We have some retrospective data from the time before we were doing identifying molecular glioblastomas, and we were treating these patients just like low-grade tumors, right? Because we had no idea, and we didn't. This manuscript has been created. It's not been submitted yet. We saw that if you do a good resection of the FLAIR hyperintense tumor, those patients have the same prognosis as IDH wild type low grade, but those are rare, right? IDH wild type low grade are rare, but they have the same prognosis. They remain stable very, very long. But those patients that have more extensive disease, we will move forward to the radiochemotherapy. And they would also have more rapid progression because they have more extensive disease and contrast enhancement. So it's just a point. So usually we do it because everybody expects us to do, and the tumor board always says we have to do it. So usually we do it, but I think we still have to think about that a little bit because these are tumors that behave like low grades at the moment, and they don't have a high mitotic rate. I mean, somebody might want to confirm that, Leonid. And so I would at least question this aspect. But this patient received radiochemotherapy. Or anybody else have any ideas about this?
But this patient's got residual tumor. Linda, what would you be doing?
Yeah, I do usually operate on these in the intraoperative MRI. So if that subcortical frontal region was anterior to the motor tracts, may consider trying to resect that in the initial stage. In these diffuse cases where, especially where the tumor gets closer to the motor tracts or others, I do agree that considering chemoradiation in a young patient, could. I think the balance is the residual tumor and the pattern of growth in a salvageable location. So if it was in a very safe and salvageable location, then some period of observation might make sense. But in this particular case, with the biology of the tumor and the infiltration that you demonstrated using the PET scan, I think moving forward with adjuvant therapies makes a lot of sense.
Right. So any other ideas about this? Otherwise, we'll move forward. What did we do, Doro?
Yes. So we did radiochemotherapy with temozolomide, sister protocol, as said before. And then the patient came for the follow-up 2 months after radiotherapy. He was clinically unremarkable, and we see that on MRI there is a stable disease. There's no blood-brain barrier disruption, and the patient also had an FET PET again, which was unremarkable as well. Then he went on with his therapy and came back for the next follow-up. Now he has finalized the adjuvant treatment, and now we see that there are new hotspots. Like on the right side, on the right frontal side, there is a new disruption of blood-brain barrier, and on the left parietal as well. So we took an FET PET again, and this revealed that there was increased trace uptake consistent with high-grade tumor progression.
And Doro,
And
can you
now,
just say how far this was after the radiochemotherapy when we're thinking about pseudoprogression? Do you have that in mind? I think it was still during the pseudoprogression phase, right?
yeah, I think it was at the end of tumor progression time. So yes, it could still be progression. Or what do you mean?
Yep, that was.
Yeah.
Okay, so what now? What would the surgeons do?
So there will most likely be a distant recurrence. So I would strongly recommend a biopsy of that left parietal lesion.
Yes, it sounds good. That's what we did. So our therapeutic plan
was
Hold
the
on.
aim of the biopsy?
Sorry.
Yeah, to go further, to just get more molecular insight into the biology that may have changed over time.
Can you
Well,
go
it's just
back to
interesting. I presume that's out of the radiotherapy field. So
Could you go back
anyway,
again, Doro?
I don't know if I would have biopsied or not. So not right or wrong, but
Could you go back the one image, Dorothy?
Yes, of course.
So question here, we now have the FET PET. So obviously we have some strong uptake in the old region with enhancement, which is just on the verge of being outside of the pseudoprogression phase, and we have the new lesion, right? Distant lesion. So any other ideas of what would the surgeons do here?
I agree with Kate. I mean, I don't know, Walter, if I would have biopsied that, I probably would have got a short interval study to kind of see what was going on here. But I think the PET is pretty convincing.
Okay, anybody else?
I mean, you can make I mean, if the recurrence on the right was solitary, I would consider re-resection. But now you've got a horrible multifocal disease. So I'd be looking for some sort of additional adjuvant. I guess if you've got a clinical trial option, you need molecular data for, updated molecular data, then a biopsy is very reasonable. I don't think it's a bad idea.
You think it's a bad idea?
No, I don't think it's I don't think it's
okay.
wrong. It's probably just not what I would do.
Right.
No, I think you're totally right. I mean, from a response assessment point of view, it would be totally sufficient to have a look at the images. Yeah.
I'm curious, although the contralateral side has probably not received radiation and would be sensitive to that, what would you do for the ipsilateral side that was probably within the prior radiation field?
Well, that's what I was saying. I mean, putting the contralateral side apart, I'd aim for re-resection, but then I guess the question is, you could treat that on its merits and irradiate the new lesion. This is a horrible thing disease.
He's still perfect. He has a Konofsky of 100, right? So he's still in perfect condition, and he has these two lesions, young guy. Okay.
Okay.
So
Go hard, re-resect, re-irradiate.
Right. Okay. So what did we do? So I was when this was my patient. So obviously, what I thought was, I'm not sure about the lesion on the right side because it might be pseudoprogression. I'm quite sure about the lesion on the left side. Well, we always have this idea about getting new molecular data for to see if there's any molecular options, targeted options. So that's why we very liberally perform biopsies. I think that's what we did, right, Doro?
Yes, we did. So we took We took a stereotactic biopsy of the left parietal lesion. So we wanted to confirm tumor progression as we suspected. And during the same procedure, we also took a stereotactic biopsy of the right frontal lesion because we wanted to differentiate if the contrast-enhanced lesions were radiation necrosis or tumor progression. And then we thought about another option. It's photodynamic therapy, which is not a standard procedure in German hospitals. This approach has been investigated and established in clinical trials in Münster. So 5-ALA is administered orally preoperatively, and then the tumor cells convert the FALA into protoporphyrin 9. And then there's excitation with red laser light, and reactive oxygen species are generated, and that leads to tumor cell necrosis, apoptosis, vascular damage, and local immune activation. And then we also aimed to do NGS panel again, because during the first operation, we saw that there was no targetable mutation, and perhaps now there's a choice that we can target, that we have a suitable targeted therapy. And we plan to do re-irradiation and CCNU administration. And this is how it looks like. And then we took frozen sections on the right frontal side, and the histopathological colleagues said that this was infiltration zone of the known glioblastoma with additional radiation-induced changes and malignant glioma. And on the left parietal lesion, we saw that it was malignant glioma. And then we also opted for a second surgery. We did a microsurgical fluorescence-guided tumor resection in the right inferior region again, and on the right frontal lobe under intraoperative neuromonitoring. Again, we did it under CST mapping and continuous monitoring, and this time we saw that there was marked FALA fluorescence, which is predictive for higher grade glioma. And then during the operation, we also saw that there was MEPs unchanged, and in the end, there was no residual fluorescence post-resection. Then after a while, we got the histopathology, and we saw that the proliferation index was higher than it has been before. And we detected an unusual FGFR TACC3 fusion, which was not detectable with the prior classification. And Leonil, perhaps you can comment on this, that there was this unusual FGFR TACC3 fusion.
Yeah, so I was thinking about making a comment on that when I saw the diffuse infiltration, because we see that indeed enriched, that some of the diffusely enhancing lesions that are quite extensively infiltrating can have this type of fusion. As far as I know, there's a new classifier from the Bethesda available from the US that would pick up this profile, at least in the future version. I couldn't see a spot on the CNV profile. So usually you see that in chromosome 5, that they're like similar to the BRAF fusion. Also, there are some dots going up, but it's not 100% sensitive to detect that from the CNV profile. What additionally could have helped in that situation initially would be an FGFR3 immunohistochemistry, which is very reliable and a very nice screening marker for this type of fusion that has officially from the EANO guideline not the direct treatment recommendation. So it's not a target that you can directly, at least in Germany, as far as I know, apply for a drug. But it's one of the attractive targets that it could in the future become relevant for targeted recommendations with FGFR3 inhibitors, for example. Yeah.
Maybe
Can I
that's
ask, was that fusion protein, was that in the new tumor, the old tumor, or both? Ipsilateral, contralateral, or both?
I think that this fusion was only in the new tumor tissue, and it was on the left parietal lesion, so the tissue from the left parietal lesion.
Interesting.
I'm not quite sure if they searched for this fusion on the right side as well.
So maybe you could go back one step, the last slide, and I'd like to hear from the neurosurgeons on the images prior to surgery.
Prior to surgery, yes.
Yeah.
This
Okay.
one?
Yeah, that one. So now we know that the left parietal lesion, subcortical lesion, or the imaging, okay, is glioblastoma, right? And it's very focal. And the other is also glioblastoma. So we'll see some images. I'll have to take out the right frontal one because it's also been pre-treated. Would anybody, knowing that it's a knowing that it's a glioblastoma, would have taken the left parietal with open surgery using a tube system or something? In this case, no, Costas.
Yeah, I don't think I would
Ecosystem.
have. I wouldn't have. I mean, I have a couple questions. I mean, in regards to the left parietal lesion, that may be a nice target for radiosurgery, a small circumscribed recurrence. We've been doing that here. But my question was, in terms of fluorescence guided surgery, can you comment on why you think the tumor fluoresced now when it didn't the first time around?
Oh, because the first time around it was microscopically, it looked like a low grade. Remember, this was a molecular low grade, so there were no aberrant vessels, no necrosis. So that's why it wasn't fluorescing. So it didn't have a very high mitotic. Well, it was about 10%, right? But it didn't fluoresce. Now we have a full-blown glioblastoma with everything that belongs to it, right? With the vascular proliferation and so forth. That's why.
Yeah, it was
The
interesting
glim
because it's an IDH wild type. It was an IDH wild type
Mm.
tumor originally, so it was a GBM, just non-enhancing GBM, basically.
Right. Those ones don't always enhance
That's right.
the
Yeah.
fluorescence. Okay, but I think maybe Kate, would you have done anything differently here? Or
No, I mean, I think we need to, because we need to wrap up for the next case. I mean, I think
true.
sort of for the audience, I mean, once you've got the second scan with the multifocal glioma, you make some sort of surgical strategy, but then use whatever your local research or clinical trial option available for the patient. And I was just wondering, how's the patient doing?
We'll move forward just very quickly. I know we have a limitation
Yeah.
on time. So this was what happened. So 48 hours afterwards, so I did the resection, the right frontal resection, so the contrast enhancement is all gone. Then what we see at the left parietal, that's a typical reaction we would see with the with the photodynamic therapy. And 1 month later was still there were new contrast enhancement, right temporal. And the left remains sort of stable because we don't know what we're actually seeing with PDT. You see these reactive changes all the time. And 2 months later, it progressed. So obviously for us, it wasn't a surgical patient anymore. The only thing I wanted to comment before we finalize this is those areas that we operated on, right? Those areas that they remain clean. And it always tells me, well, we might be doing something sensible. We're even resecting these parts of the tumor, even multifocal disease, right? Even though at the end it's going to still just continue. Okay, do you want to maybe show the last slide, Dole?
Yeah.
Okay, so just very quickly.
Yeah,
What did
yeah,
we see?
okay. So in the end, the therapy was changed. So he received an mTOR inhibitor, temsirolimus, and also peropaneal, which inhibits the AMPA receptor and inhibits neuroglioma synapses. And now that he got progressive disease, unfortunately, we do not have the MRI scan of that. And then they switched to a vascular endothelial growth factor inhibitor, bevacizumab, and the fibroblast growth factor receptor inhibitor, erdafitinib. But then after weeks, there was progressive disease again. And finally, after a few weeks, the patient died, unfortunately. So I go to the take-home messages. First of all, molecular criteria may upstake histologically low-grade lesions as wolf in sheep's clothing. Then FET-PET is useful in differentiating progression from radionecrosis. Targeted biopsies can be helpful to confirm multifocal progression. And even in multifocal gliomas, surgical intervention retains its value in tumor management. So I thank you for your intention and for the lively discussion.
Okay, and I will suggest, for the sake of time, if there's any questions or comments, please put them into the chat. And if we have more time at the end, we can address them. Otherwise, we'll move forward to the second case, if you agree, Kate and the others.
Can I just ask one question?
Yeah,
How
sure.
long did the patient live? What was their overall survival in the
It
end?
was like 2 years. 2 years.
Yeah. So that, unfortunately, as expected. Okay, Sarah Kane, young neurosurgeon from Melbourne with a case of a complex meningioma. Thanks, Dorothy. That was a great presentation. Really interesting case.
And how does that look?
Yep.
All good?
Yep, good.
Cool. Thank you for the opportunity to speak tonight on this case. I'm a neurosurgeon at the Royal Melbourne. I work with Professor Drummond. I'm dual fellowship trained. I was lucky enough to do my neuro-oncology fellowship with Professor Drummond in the Brain Cancer Centre, where we did our IDH inhibitor trial. And then I went off to Cambridge to do a skull-based fellowship. And now I'm back at the Royal Melbourne working there with some work at the Peter MacCallum. So this case came in before I went to Cambridge when I was on call. And it was a 30-year-old right-handed man from the country who had a motorbike accident and hence had a CT trauma series. He had no past medical history, didn't take any medications. He was partnered with 2 young children and he worked locally as a concreter. His major injury from the motorbike accident was this L1 fracture, which was managed conservatively by the spinal team. The reason he was referred to me was this is his non-contrast CT brain, which showed this ill-defined mass throughout the middle fossa, extended into the posterior fossa and down through the skull base. So upon referral, we asked for a MRI scan. I'll put some videos in because it's a little bit easier to see the tumour, which I'll scroll through for you. So the T1 post-cron, you can see this tumour here pressing up against the pons and then forward into the middle fossa. Down there, you can see it going through foramen ovale into the infratemporal fossa. So quite an extensive tumour. So I'll just show you on coronal view here. You can see that posterior fossa component there coming up against the basilar, the middle fossa component. There's some there going through in the cavernous sinus encasing the RCA, and you can see that component there going down into the infratemporal fossa. And just finally on axial, you can see how that is displacing the pons there and how extensive that supratentorial component is there. So just to show you the CT brain, you can see that there is some hyperostosis there, some expansion of the foramen ovale, and some hyperostosis there of the sphenoid wing. And coming down here, you can see that sort of that remodeling there of the maxillary sinus. So I've got this young 30-year-old gentleman who's completely neurologically intact. He just stacked his motorbike while out on the farm. And he's got this multi-compartmental large tumour. So just wondering everyone's initial thoughts about what we should do here.
Okay, surgeons. Linda?
Sure, no, this very tough case. I think he has 2 great things going for him, which is that he's young, and or 3 things. 2, that he does not yet have symptoms, and 3, that this tumor is all connected in some sense. So thinking about, the basic reasons why we offer surgery for anybody, which is to improve their quality of life or their quantity of life, either immediate or in the future. I think to be very clear with this person, their ability to recover, the tempo of recovery, and the potential for future treatments. I would think about this I do think he would benefit from surgery because these sphenoid wing or this region tumors that go into the infratemporal fossa, I find have a higher incidence of atypical behavior than the pure sphenoid wing or sphenoorbital meningiomas. I think the goals of the surgery would be, number 1, to decompress the brainstem and to preserve his future vision. So at least for me, I would offer him a surgery, probably starting with a cranioorbital zygomatic approach to broaden the access to the infratemporal fossa, drilling of that sphenoid wing to widen the door into the infratemporal fossa, anterior clinoidectomy to peel the cavernous sinus, possibly looking at your window into the posterior fossa component, possibly an anterior putrescectomy. In terms of all of this, within the cavernous sinus will depend on the texture and whatnot. Of all this, the infratemporal fossa component, which is quite large, I think the extent of resection there depends on the texture of the tumor. Sometimes it's quite firm for whatever reason within that region and not so easy to distinguish between the pterygoid muscles and such. I think the main issue with that, I know after counseling for trigeminal sort of distribution numbness, is that of jaw pain and trismus and such. And so that component on the T2s, it looks like there is a capsule or some sort of boundary once we get past that initial window past the pterygoids. But I think that will be an intraoperative decision making. Probably the biggest risk of this operation, at least in my mind, is that of CSF leak. And so if there was an extensive infratemporal fossa resection, to be careful not to violate kind of the walls into the sinus, because it would be a massive hole such that it can still be reconstructed with fat or localized, rotational of the muscles. If that were to be resected, would be the kind of biggest concern in my mind.
That was comprehensive. Aristoteles, do you have anything to add?
Yeah, first of all, I would discuss, differential diagnosis with him. I would say that's most probably a meningioma. We see some bone remodeling, thickening, but we also see some anatomical driven growth that we also see in schwannoma. So I would put that in my differential as well as a second working diagnosis. And then I would discuss with him the nature of both diseases. And say that most probable a surgical intervention would be to his benefit. I would lay down the risks. I agree with Linda. One of the major risks would be the CSF leak. In terms of the goals of resection, I would probably be straightforward with the patient and say that we cannot get a gross total resection of this. There is a cavernous sinus component of the tumor with encasement of the ICA. So I would plan for a generous subtotal resection and leave that cavernous sinus component for later adjuvant treatment according to the pathology, with SRS and fractionated radiotherapy being options. Now, in terms of the surgical approach for this, it's quite complex. I guess many options they're out there. I would probably do a staged approach and leave the extracranial component to deal with a kind of a second stage operation. I would do kind of a orbidozygomatic, as Linda suggested, or a pretemporal, and then see what's the consistency of this. The tumor, in a sense, has done the Cavazzi approach itself. So if you do an anterior clinoidectomy, extradural peeling of the middle cranial fossa, you probably have a petrous apex which is invaded by the tumor itself. So probably not a lot of hard drilling there. And the first goal would be with this operation to decompress the brainstem and get a maximal safe resection. And then according to the texture, to the consistency of the tumor, I would decide on my second stage operation for the infratemporal fossa. One option is if it's hard and vascular, I would continue kind of a preauricular incision, have my ENT colleagues or head and neck involved and try to do an open approach. I guess drilling of the middle fossa is necessary there to expand on the foraminal valley and get access to the infratemporal fossa from lateral. It's quite large. Otherwise, if it was smaller, I would also discuss if it was smaller and it was not vascular in the first operation, I would also discuss an endoscopic approach, either a transmaxillary or a transpterygoid, incorporating probably both nostrils with resection of the posterior septum to get access laterally to the infratemporal fossa. So yeah, this would be my discussion, my options laid out to the patient.
Sarah, what did we do?
So first I brought the patient down from the country and met him. And
Yes,
examined him.
remembering that this is a young Australian man who just wants to ride motorbikes around on a farm.
And I examined him twice, and he was definitely neurologically intact. And we went through his scans in a lot of detail. And unfortunately, he was referred just before I was leaving for fellowship. So I handed him over to one of my colleagues. But nonetheless, when we were looking at this tumor, as you all said, it's quite an extensive tumor. And we were looking at the different components and how we would stage surgery and how we would approach it. And the patient was very risk adverse. He wanted to stay on the farm with his kids and not have any deficits. So we first looked at the middle fossa component and thought, we could do an extended terional and move that component. The cavernous sinus component, initially we thought we'll leave that alone, we won't go in there. The infratemporal extracranial component, again, in the first step, we were leaving that alone. And then we'd look at a second stage doing a retrosigmoid craniotomy to remove the component that's compressing the brainstem. So his stage 1 was that terional craniotomy. Stage 2, we've left these 2 sections. So that's how we sort of broke it down. And I guess we've spoken about what we'd do first and how people would combine it. But we went ahead and did the terional, standard terional dissection down to the optico-carotid triangle, showed optic and ocular motor, everything pretty routine. The tumor was resected piecemeal. It was quite adherent to the inferior temporal gyrus, so there was some resection of that. And the coagulation of the dura of the middle fossa floor without entering into the cavernous sinus. So this is his post-op MRI scan, and you can see that tumor is still there, bulging out the cavernous sinus with that main component all removed with preservation of the MCA running through there. And you can still see that posterior fossa component, obviously, and just in all 3 planes. You can see how that floor of that middle fossa has just got that thickened area that was coagulated. And again, just on sagittal. So after this surgery, he went back to the country and he decided he didn't want to do the second stage surgery. So it took quite a while, and I just got back from Cambridge in time for his second stage, which we did via a retrosigmoid craniotomy with NIMS monitoring. We opened up and 9 to 12 were down below the tumor. We saw 3, 4, and 6, which we preserved. In this picture here, you can see 7 and 8. 7 was stimming great at the end of the case. 5 was our main problem. It was pushed inferiorly and quite encapsulated over the tumor. You can see this is the cavity of tumor here that we're still resecting, but we managed to get it off. However, we did leave a smaller amount, which is up against the basilar, but otherwise got a good resection. And this was only just done recently, and I don't have a post-op MRI scan, but this is his CT, where you can see the resection of that component that was compressing the brainstem. So for the neuropathologists on the panel, I've got some slides for you of his results, which I could describe or you can expertly describe.
Leo, you might want to make a comment. I think we sent them earlier as well.
Yeah, so I think it's very nicely described. So we have a medium cellularity tumor that has some mesenchymal aspect to it. It is rather of lower pleomorphy. It has some clear nuclei in that and a very limited wall formation. So for us, this would very nicely fit to a meningioma, of course. So
Yeah, just some other pictures here. There was some intranuclear pseudo-inclusions that we highlighted. Some very rare Simone bodies throughout the H&E staining. And then we had the SSTR2A, which was strongly positive. So the histopathology report came back as WHO grade 1 meningioma. As we all know, the classification was slightly altered in the 2021 change with the addition of the TERT promoter and the CDK2NA, and some change with the grade 3 for meningiomas. And I point this out because in this paper that they published, it was mentioned, this case where there's two patients which had histologically grade 1 meningiomas. However, one had the CDKN2 deletion, which is the bottom one you can see on the post-op 1-year scan, very strong recurrence. So although our tumor is histologically grade 1, we haven't done any sequencing on it. So I guess where to now for this young guy? We've done 2-staged surgery. We've still got this extracranial component and we've still got this cavernous sinus component. Should we be sequencing this to guide how aggressive we need to be? Should we attack the extracranial component? And what should we do for the cavernous sinus component? I think we've discussed it a little bit. But basically,
Just before you go on,
yeah,
Michael, what do you think about this multi-staged approach to the tumor?
Yeah, I just want to have one question ahead. Did you do any sampling from that adherence to the inferior temporal gyrus? An extra sampling, send that off separately to rule out brain invasion?
it wasn't sent separately.
Because there's a discussion currently going on in Germany, and there's a study running, an observational study called the Invader study, run by a friend of mine called Felix Behling from Augsburg, Germany, and they're sort of looking into that. I think that is something that we as surgeons should definitely keep in mind, that we should not only send off the chunks, but to really, if we see a brain invasion or feel that there's brain invasion, to send it off separately. Yeah. And regarding the multi-staged, I mean, I like Linda's idea of doing a very generous approach, like an FTOZ or FTZ or whatever, to really get it all in one stage. I mean, that's definitely something you can discuss with a patient and how risk-friendly he or she is.
I also think there's a question about how aggressive you need to be for the extracranial part of the tumor, but I guess you're going to say something about that. Dr. Lazaridis, would you be jumping in with any adjuvant therapy at this point?
No, I would not be jumping in with any adjuvant therapy. I think surgical resection is gold standard. Then radiotherapy plays a vital role when surgery is incomplete or not possible. And chemotherapy, I think, demonstrates limited benefit. And advanced molecular testing or profiling would be good for me to have more options.
Yeah, I just have one
Okay,
question
Sarah?
regarding this
Yeah.
case, Kate. So 30-year-old with step tumor, that's very rare. And so he has no radio, so no exposition in the past to any radiotherapy or something. That's one question. Could it be a case of NF2 without bilateral acoustic neurinomas? Does that make sense? It's just that such an uncommon case. I don't know, maybe in Australia it's different, but we don't generally see these large tumors in 30-year-olds. What do you think?
No, very unusual.
It was very rare.
Yeah. No, I agree with everything that's been said here. I would probably go for the orbital-zygomatic and try to do the transpetrosal approach and see if I can't get that mobilized in the initial approach, but I would do sage also for this for the subtemporal part. We wouldn't do that at the beginning for sure.
Okay, Sarah, we have 5 minutes.
Okay, I'll zoom through, but basically that, as we said, that extracranial component, it's rare. It only occurs in 2% of meningiomas. And Hoy postulated 4 theories for that. And obviously our case is due to that extension through the foramen ovale, which forms a part of the roof of the infratemporal fossa. I mean, when you look through the literature about approaches and how to attack these tumours, it is quite sparse, to be real. There's a lot of case reports out there, but not a lot of studies. There's an old study from Tokyo in 2009 that suggests some of the approaches that you've all suggested and on how to attack this in one approach. But I think the discussions between the surgeon who actually did the surgery with the patient, who was very risk adverse, was to just try to reduce the bulk of the tumour with least risk to him. In regards to the cavernous sinus component of it, I mean, this is the consensus statement from the AANS skull base section published in 2022. As they suggest, you need a multidisciplinary team approach. You can consider surgery for those aggressive lesions in young patients. And endoscopic combined with radiation is effective. And I quite like how they, in this paper, explore the anatomy and the tumour growth and describe the tumour growths which are favourable to surgery. In this picture, they show that pattern 2, where the tumour is growing laterally, is more favourably to your open surgery, where your pattern 3, where they're pushing the nerves laterally, is more favourable to your endoscopic approaches. But your pattern 1 and 1A obviously are less favourably to surgery. And I think if you look at our patient scan, it's more in keeping with 1 and 1A than it is with 2 or 3. So that leaves us with stereotactic radiosurgery, which has a reasonably good 5-year progression-free survival of 96% and only dropping to 90% at 10 years. So that's where we're at with him at the moment. He's had that 2-stage surgery. He's back on the farm. He's still neurologically intact. He's happy, but we're still seeking a head and neck opinion on the extracranial component and a radiation opinion on the cavernous sinus component. Thank you.
Any comments from the panel?
Yeah, I have a very academic question. Would you really say that this is a cavernous sinus meningioma, or was it? I mean, I haven't looked at the images that thoroughly as you did, but would that be sphenopetroclival, or what was your impression from intraoperatively?
It looked like there's within the cavernous sinus. Obviously, I wasn't there for that surgery, but that's what I was told.
Can I just clarify, did you say that this particular tumor has CDKN2AB loss? Or was that just referring to the report?
No, I was saying that we haven't tested for that. And I was postulating, is this something in a young patient with an unusually large tumor, something that we should consider routinely checking to guide how aggressive we should be? Because if he does have a deletion, maybe we would then be more aggressive in our initial surgery despite his risk aversion.
Yeah. We do have the luxury of doing chromosomal copy number alteration in every meningioma. And as you probably know, pediatric meningiomas are far more enriched for higher grade tumors, also more likely to be non-dural based and to be in unique anatomic compartments. So at age 30, tough to know if this originally was emerged or was born as a pediatric meningioma and then evolved over the subsequent, decade or 12 plus years to be this multi-compartmental entity. And especially since he remained without symptoms. My sense is that the excellent control rate in some of the cavernous sinus radiosurgery studies are because it combines both lower grade and higher grade tumors. And many of the observed cavernous sinus components or true cavernous sinus tumors, can be very indolent for a long time. Whereas those that progress and are truly higher grade may not have such, perfect control and will track up the tentorium and other compartments in a very insidious way. I think Michael's question of do you consider this a sphenopetroclival versus a cavernous sinus meningioma, even though there is infiltration of the cavernous sinus, the bulk of the cavernous sinus component does not seem to be expansile, and so the epicenter of the tumor, may still be more in that sphenoid wing compartment, allowing it to both grow down into the infratemporal fossa and posteriorly into the petrous apex sort of region. The petrous apex, but although I may have misremembered this when you were scrolling, the CT itself did not seem to be particularly remodeled or eroded or hyperostotic. So it seemed to be a secondary extension through Meckel's cave to that posterior fossa, causing the brainstem compression there. But I guess the bottom line is that we probably would do some sort of copy number or molecular sequencing if it was low grade to watch as long as possible, because I do worry that in higher grade tumors, in a young person, that there is a durability to any form of treatment we give, whether it's surgery, radiation, or both, and to try to stretch out, kind of get the most bang for the buck for every intervention so that they get closer to their natural lifespan, has been our formula.
Yeah, I think to Walter's point, it would be important to make sure that this is not actually syndromic as well, given age and everything else. So, Sarah, that's for us to do. Sequence the tumor, get the syndrome, work that out, send him to genetics. But we are at time. Costas has turned on his camera, so we must be in trouble for going over.
No, you're not in trouble. This is an amazing discussion. If we need to go a little bit longer, that's fine.
Oh no, I think you know how these things are. We could go forever.
We could go on and on.
We've cut it back from three cases to 2 cases. So maybe I'll just thank our 2 presenters, Dorothea and Sarah. Thank Walter, my co-chair. Thank Costas for being in charge of everything. Patricia for organising. The 2 Marias for their fantastic organising. And our panelists from Germany, Athens, and the USA, which makes this a very for Germany, Greece, and the USA makes this a very international, and Australia very international exercise. And thank you very much, everyone.
Thanks, everybody. Great job.